So everybody that is joining in, welcome to the OGS Urogynecology Journal live session with our wonderful expert guests, Dr. Kim Kenton, Dr. Catherine Matthews. We're probably going to be on this live for about half an hour at most, so hopefully you all.
Oh.
There was a long pause. Was I the only one paused?
No.
Pause. She's paused for me too.
I think Kate's paused.
So hopefully you can all get some good, excellent content. I'm Kate Meriwether. I'm one of the editorial board members of the Urogynecology Journal. And Stephanie Paxson, our wonderful liaison from OGS, is also joining us tonight as running the @OGS Society host of this live. If you have any questions, please feel free to put them in the chat. We'd love to address them as we go through the live. My wonderful expert guests this evening are Dr. Kimberly Kenton and Dr. Catherine Matthews. Dr. Kenton, to introduce her a little to you, she's the Chief of Female Pelvic Medicine and Reconstructive Surgery and Department of OB-GYN at the Feinberg School of Medicine, Northwestern University. She's got decades of experience as a leader in the field and more publications than we could possibly discuss, but she's published on such fascinating gender topics as differences in language with letters of recommendation for residency, different reviews of patients to providers with different provider gender identities, and of course, leader disparities in OB-GYN departments throughout the country. Because of her expertise in this field, we did ask her to be a guest on this Instagram Live, and she was kind enough to invite her respected colleague, Dr. Catherine Matthews, who's also joining us. Dr. Matthews is a professor in urology, OB-GYN at Atrium Health, Wake Forest University, also has decades of experience as a female pelvic surgeon, and has mentored and guided countless learners and surgical trainees to be wonderful women, men, and other gender identities in the field, being surgeons and taking care of women. Her research is very focused on surgical outcomes and excellent surgical care of patients having this disorders of shame and silence, particularly women that are suffering from things like prolapse, bowel incontinence, etc. So thank you, ladies, for being here and talking about a very sticky and yet enlightening topic, gender equity in surgery. A lot of people make the joke that we're going to continue to talk about this topic until there's no topic to talk about anymore. So we'll certainly kicked off by sort of what is gender equity? What is the definition in your minds as experts of the topic that we're talking about tonight?
You want to take it, Catherine?
Well, you know, gender is such an interesting thing at the moment because I think it's so recently defined as something that people are paying a lot less attention to in terms of this dichotomous evaluation of men versus women. It has become so much more fluid, but in my mind, this is talking about equal access of people who define themselves however they want to define themselves to every opportunity in the workforce, both on the positive and on the negative side of the equation, that we all should have equal access and equal responses to each other, both for opportunities and for, you know, if someone is being remediated for behavior, that they should be treated the same way on that side, as we see inequities on both the opportunity and on the remediation side of the coin.
And Kim, what do you think? What is the definition of gender equity as we're going to talk about tonight?
Yeah, I mean, I think that for me, gender equity, and while I definitely want to be inclusive of, like, you know, all genders, I do think that as women in women's healthcare, we have to be a little bit careful to not not to lose our identity as well. I think that that's a very important thing, that we don't have to lose our own identity as women, but still be inclusive of many other people who also need to have a seat at the table and have equity. So to kind of relay on what Catherine said, I think that gender equity really means fairness of treatment of, you know, whether you wanted to have two genders or, you know, a more inclusive thing of gender. I think today much of what we're talking about is about female and gender bias that some of us have women in the field and have experienced. And I think that there's a lot of talk about equity, but I think it's really important that this fairness of treatment, and I think that Catherine brought up a really important point, is it's about opportunities, but it's also about, like, you know, we've talked a lot about in the past about perceptions of leadership. Like we know what leadership, like positive traits and for leaders are to be dominant, to be confident. But those are very opposite of the characteristics that women are supposed to display in the workplace, which are supposed to be nurturers and caring. And that puts us into a lot of sometimes conflicted roles where I think, to Catherine's point, we are sometimes unfairly treated, and the way people respond to us. And so I think that, to Catherine's point, I think it is fairness of treatment, both in opportunities and in like outcomes. And it's really, I think the most important thing is equity is really a means to attain equality, which is what we really all want. I mean, the end goal isn't equity, the end goal is equality, and equity is just the means by which we're going to get to equality. So I think it's important to talk about equity, but I also think it's important to focus on equality. And, you know, in the paper that we published about women achieving leadership positions in OB-GYN, you know, we redid some of the work of Hope Ricciotti and her folks did 10 years ago. And, you know, we know we're not achieving equality yet, so we need to talk about these equity measures in order to get to equality.
Awesome. And the two of you brought up a really great point that I think needs to be made before we go on. A lot of the language that we're going to be using in this conversation does still use some of the dichotomous things to talk about gender. For example, I'm going to say words like women in this talk. And when I mention women, particularly in the context of our usual patient population or in talking about surgeons or providers, I might be talking about individuals who identify as women and who had female genitalia or pelvic anatomy at some point in their life. So keep in mind that we're going to use language that may come across as exclusive, but we're trying to mean people that consider themselves to be women or had women-like traits that we're talking about. Who do you all feel is being affected by gender issues in urogynecology today? Patients, surgeons, providers. So who are we talking about? Who's got a skin in the game here?
I mean, I guess who's not being impacted by it, right?
Yeah.
You know, Kate, I really do think that the female surgeons are the ones that are affected most, in my opinion. I think that our patients are getting fantastic care, and it's spectacular. We've got such an amazing representation of females in urogynecology. And so I think that as a surgical subspecialty, we're probably affected a little bit less than things like orthopedics and neurosurgery. But the fact remains that as female surgeons, we continue to run up against implicit bias. We continue to run up against these very, very, very conscious behavioral norms that Kim alluded to, where women are really expected to exhibit these communal traits, as opposed to having these agentic traits that men exhibit. And female surgeons, unfortunately, often we are assertive, and you are more likely to be perceived as pushy and as aggressive, merely because you're exhibiting these more characteristic male traits. And so I think that as females, we have to be super aware that if we're just being if we're just exhibiting the same traits as men surgeons, then we'll be treated differently. Then different leadership opportunities may not be there for you. You may have more struggles at work, and so it's an uphill battle, to be completely honest. And it's represented in the fact of we don't have the highest leadership positions. We're very, very underrepresented in the upper echelons of leadership,
particularly administrative leadership. And I think that, while I do think that, probably to Catherine's point, that it's better for us than it maybe would be in orthopedic surgery. However, when you look at numerous studies that look at different issues of gender equity in different subspecialties, OB-GYN is like the fourth worst. And that like comes up multiple times. So as a field that's for many, many decades now has been predominantly female. I mean, like, so, I mean, for 30 years, the majority of our trainees have been women. So this isn't like new. And yet we're still like at the very bottom of the pack. And perhaps it's because if you're in a more, let's say, male dominated field, they've had to pay attention and they've been forced to address some of these issues where in OB-GYN, we've been able to sit back and, you know, because there are so many women around, it seems like there's a lot of women and we're not really paying attention to the fact that like there's a lot of women here, but they're not reaching the highest levels that we should have, and men are overrepresented in leadership.
Absolutely. And I love that some of the allusions that the two of you made were to the fact that sometimes folks exhibit traits that are considered traditionally female traits. And even if they're being exhibited by someone who doesn't identify as a woman, like someone who identifies as a man, is nurturing or is collegial or is supportive, that those traits are discriminated against, if only because they're perceived as female, even if it's not a female exhibiting them. Does that make sense?
Yeah. And I think that we've all like experienced when we walk into the operating room, and if we know it's going to be a tough case and we're going to need to take control of the OR to protect our patients and make sure everybody's safe, that after you've been in that critical situation, I mean, I've talked about this with male colleagues. I mean, you know, you have at the end of the case, you're like, oh, you know, thank you so much for everyone, you know, being supportive, and you know, you make sure to ask about everyone's families, and those are things that when you talk to men in our field, they're like, what? I mean, like, why would you do that? And I'm like, yeah, like our lives are just different.
You know, Kim, one of the studies that I find so illustrative about the OR environment is this really interesting animal behavioral specialist, Franz de Waal, did this incredible experiment where he observed 400 doctors, nurses, and patient encounters in like over 200 operations. So this incredible number of data points to try to understand if humans behaved like animals. This guy's like a chimpanzee expert. And we know that within the chimpanzee world, there's a whole lot of jostling for power, and chimpanzees either being collaborative or being very hostile. And what he found was that when same-sex teams worked with each other, they exhibited a lot of these same traits where they were hostile with each other, as opposed to being in mixed sex teams where people were much more docile. They were really kind of catering to the opposite sex. And I think if you think about female surgeons, we're in a situation all the time, more likely than not, where you have female scrub personnel, female circulators, and it sets up this dynamic in the OR where it becomes this jostling, hostile environment often to the female surgeon, and that male surgeons never experience because they enter into this environment where it's a mixed sex team more likely than not. Yeah. So I think that animal experiment was really, really helpful to explain some of these crazy unconscious biases that women surgeons face, that have got nothing to do with anything other than like these animal behaviors that are exhibited in people.
Yeah, and
so we do act like chimpanzees, is what you're saying.
That's right.
You know, but I think that pans out in the data, like the study out of Stanford, where they looked at like patient reporting systems, which, I mean, are so misused and abused right now. I mean, those are to identify system failures to protect patients. And, you know, we've talked about it a lot at our own institution, and we're so pleased when that study came out, which pretty much said that like women and underrepresented and medicine groups are more likely to get like these patient reported system, you know, documentation for basic little things like things that were classified as inappropriate communication or lack of communication, where men, when they finally get written up, it's for like doing really egregious things, like they physically intimidated someone, and how all these systems are just set up to hold women to a different standard.
Yeah, it can be very discouraging, but I want to go back to something that was said earlier. We're taking excellent care of our patients. What does the data say about the role of gender in outcomes? What could gender equality do for our patients or for our field?
Yeah, I mean, there's not a lot of data in the actual OB-GYN literature about patient outcomes and gender, although gender concordant pairs and much of the surgical literature and internal medicine literature show that you're likely to have a better outcome if you have a physician of your same, like a concordant gender or race. And that's definitely, and I don't know if that's partially because we have so many women in the field that we're not going to be powered to pick up those type of differences, and it hasn't been quite as deeply explored in OB-GYN. But I think that the other thing that kind of burden that we carry, and this is well reported in both our literature and other literatures, patients have many higher expectations of us, again, regarding those communal type behaviors. Like there's good data that female physicians spend more time on my chart answering patients' questions. Patients expect them to be nice and friendly and take more time than they do with their male surgeon counterparts. And so that's just an additional, like in order, we can be equally competent as a male surgeon, but our patients expect us to have 25 additional traits and ability to spend time with them. But some of our male colleagues aren't getting the same expectations.
Yeah, it's interesting also, Kim, the retribution, if a female surgeon has an adverse outcome, is far more significant than if a male surgeon has an adverse outcome. And I don't understand truly the root of that. One would assume that one has established a really great relationship with a patient, that they would perceive the adverse outcome in the same light, regardless of the gender of the surgeon. But that's where these unconscious implicit biases come to bear. And it's been shown that the retribution after an adverse event is significantly different when the surgeon is female, which I think is very unfortunate and something that we have to try to work to overcome, although I don't have a solution to that. It's just an observation.
And is that true, Catherine, in both the hospital administrative side and the patient perception side?
I believe so. And so, that's something that, we have to be so mindful of, that women have been found to not be as kind in grading or in scoring other female candidates. It's an interesting paradox that even though we have awareness about this gender inequity and this unconscious bias, that when it comes to females grading others, they tend to be harsher as well. And so we, on some measure, contribute to this problem. And I'm not sure why that is. People talk about this queen bee phenomenon, where when women get to the top, they like to be the queen bee of the hive, and they sometimes feel threatened to let another queen bee in. I'm all about reproducing the hive and trying to empower people to create as many hives as possible. And man, it's kind of fun to share a hive on occasion too.
Really,
so
sure.
I think that we have to be aware as females at how we are contributing to the problem, and really stop those behaviors as quickly as we can identify them.
Yeah, I mean, to that, sort of on that same thought, is when they've looked at surgical referral patterns, male physicians are about 32 times more likely to refer to a male surgeon, where female physicians are only 1.6 times more likely to refer to a female surgeon. And then when patients there's a couple studies that show that if I referred you a patient, Kate, and the patient had a poor outcome, because you're a female surgeon, I'm more likely to never refer any more patients to you than if you were a male surgeon. And so it's happening to us from both, male and female referring sources. But to Catherine's point, men are really good at referring to men, but we're not quite as good at saying, hey, if there's two equally competent people here, maybe I'll refer to the female surgeon rather than the male surgeon.
Gotcha. And we had a comment in the chat. There was a question, do you feel that this phenomenon is because women feel like they have to fight so hard to get a seat at the table, that they have this sense that there's not enough seats at the table or at the leadership table, and they have to sort of not keep other women away, but they have to continue to sort of defend their own seat and interests because of the lack of seats there?
Yeah, it's possible. I think that it's interesting, the psychology of the queen bee behavior. I would say that we have to think about expanding the table, and that I think that mentality of trying to maintain central power is a very male characteristic of leadership. And there's a wonderful book called Vital Voices that tells the story of 100 world leaders that are exceptional in a new form of leadership, which is one of empowering others. And I think that is actually a very female trait that we could really embrace in terms of a different leadership style. So I really want us to think about, how can we actually take control of the situation and change the paradigm of how leadership is done, and not do it in this ideal of trying to maintain central power, but rather think about, can we work to empower more women to have seats at a larger table?
And I think, honestly, Kate, I commend you for putting this together, because these are the kind of discussions that make that happen. I mean, the reason that when you approached me, asked Catherine to do this with me, is because we've done these presentations together at SGS before, and this is something we talk about all the time. And we've put together big female teams, like if you look at everything we do. So I think that is changing, and I think that the way it's going to change is through dialogue and affirmation, and really, I mean, just like kind of looking around and having these open conversations, and honestly calling each other out. Like, when you see somebody doing something that's marginalizing another woman, like, call them out, like, pull them aside and be like, hey, listen. Or if you're in a meeting and you can figure out a way to politely, give the right person credit other than the person that's taking credit, then that's how we have to start doing it for each other. And I think it's awareness. Like, it's like everything else. If we're aware of it and we start to talk about it, that's when we can really change it.
Absolutely. As the years go on and I see more mentoring of women, particularly women surgeons, and I do more mentoring of women surgeons, it's so enlightening, because it makes me realize the mistakes, missteps, and missed opportunities that I did 5 years ago, 3 years ago, 1 year ago, 5 days ago. And having these conversations is so wonderful, because it causes some reflection, at least on my side, of ways that I could have been a better co-leader as far as being a woman in our field and supporting other women in our field.
And I'll tell you, for me, I've learned a lot from, I have a big team of people that are considerably younger than, I am. And I was really lucky. I mean, I grew up in probably OB-GYN before it was as female dominant, but I mean, two of the most powerful women in our field were the only mentors and sponsors I've known since I was a medical student. So I really didn't understand. I was a little bit insulated and protected from the realities of the world. And it's actually like Maggie and Sarah and Christina and some of my junior people that were like, hey, wait a minute, like, that's not okay. And I was like, oh, really? It's not? And that's when I really started getting more interested in the topic. And, and then Catherine and I have had a lot of conversations, and, that's when I really decided that it was something that I was going to own and try to get some of these things fixed, so we can hopefully, you won't have to endure some of the things that, like, Catherine and I and the women that came even before us had to deal with.
Absolutely. And where have we gotten some wins in this field? you mentioned that perspective of watching the field become more female and seeing an increasing number of women be mentors and leaders and things of that nature. What wins have we enjoyed over the past decade or two?
You know, I think that, look, I think women are slowly getting some seats at some hot tables. And so we are making progress. If you look at the leadership in OGS, you know, it's been really beautifully represented by women, and they've done a really great job. So I think that you know, certainly from the society's perspective, that's been a big win. I think that in terms of pay equity, it's not equal, but there have been advances and places that have put forward very specific programs to achieve equity are doing some great things. You know, at the Mayo Clinic, there is equal pay for all genders. And so I think that you know, when institutions have made these concerted efforts because of pressure, change is happening. And so we have work to do, but we've made improvements in that regard. And the other area that I think we've made some strides in is in the recognition of burnout. You know, we know women suffer from burnout much more. A lot of it's related to the fact that they are responsible for many more things at home. They're not outsourced as much. And I think that just kind of naming that and having awareness about that is helping. And the other area that I think we've made some improvements on is kind of naming the imposter syndrome. Women suffer from that much more as well. Even I didn't know what that was 5 years ago, even though I suffered from it. And, you know, I think that being able to name that and talk about it allows people to then start figuring out solutions for getting over it. So I'm pleased about progress in that regard. What about you, Kim?
Yeah, I mean, I think that as I'm proud to be a urogynecologist, because I think when you even look at data within OBGYN, we're actually doing better than any other subspecialty or specialty with respect to gender equity. And I think that, you know, I probably attribute to that some of it is that we had some powerful, strong women that were a young field, and there were some really good pioneers who paved the way for us as a field that were aware of these issues and probably made it a little bit better for the rest of us. But I don't think that we should lose sight that while we're doing great within urogynecology, as urogynecologists, we sit at the table of a much larger specialty called obstetrics and gynecology, where we still need to make some headway. There still aren't very many. I mean, we're still underrepresented in chair positions. I mean, dean positions, forget it. And I think that when you look at those higher level leadership positions that, you know, I guess I challenge people to step back and don't just look. We have it pretty good as urogynecologists. And I think that there's some pay inequities that have been unroofed. And I think, you know, some of those are also packaged into the complications of not only do we have two genders, but we have two specialties coming at our subspecialty, which contributes to the gender pay gap in our field. But I think that we have to look at the impact that we're going to have, you know, without OBGYN, there's no Urogyn, and really making sure that we have our, you know, fourth worst of all the specialties out of, you know, what are there, like 23 ABMS specialties, something like that. We're at the bottom 4.
Do we have any particular challenges with gender equity or achieving equality that other subspecialists or other specialties aren't maybe struggling with as much? What are some of our individual barriers that we have to sort of name and be aware of as urogynecologists?
I don't know that I necessarily have a data, an evidence-based answer to that specific barrier. I think that we have no unique traits or no unique circumstances that we're working through. I think that because we have a very high concentration of female surgeons, all the things we've talked about are very active barriers that we may encounter on a daily basis.
I guess one of the things that I would say, like I sort of alluded to it before, that is a unique barrier is, so right now, the way like our specialty is divided, if you're coming at it from a urology perspective, you're on one pay scale. If you're for dollar per work RVU, if you're a urogynecologist, it's a different one. And if you go back to your institution and you check to see what like the dollar per work RVUs are usually much higher for urologists than they are for OBGYNs. This is why it becomes important for us to have a 2-digit code for our subspecialty and some of the other good work that OGS is trying to do. But, you know, male procedures pay more. I mean, it starts at how much we get reimbursed by doing a procedure on a male versus a female. For example, if you do a penile biopsy, you get like maybe 3.5 RVUs. If you do a vaginal biopsy, which I think we would all argue is considerably more time consuming and difficult because it's internal versus an external organ, you only get about 1.5 RVUs. And all that has downstream consequences for reimbursement and how we get paid. So until we figure out how to bridge that gap, I mean, one of the things that I've talked about in my own institution, and some people like Eric Sokol have been able to fix this, but if your dollar per work RVU is set based on Urogyn or whatever your department's doing, and urology in your institution is much higher, like if you have an FPMRS trained surgeon that's a urologist, like they theoretically can get paid more to do a hysterectomy than any gynecologist in the institution. And so, and if you just look at the demographics of urology versus like OBGYN, there's many more men in urology, which is contributing to that gender pay gap in our field. Does that make sense?
Yeah, the double pay gap where it's more women taking care of more women.
Right.
And we're gonna kind of get hit both ways.
They're getting paid more to do the same thing because much of the way they've negotiated those things is based on reimbursement for male procedures.
Absolutely. And it's so hard for leadership to be able to tease out the reasoning for increasing our pay, right? Because they say, well, you know, we're not getting as much money from you, so why should we be giving you more? And then those conversations in some institutions kind of go round and round.
Yes, I know.
What do you doctors think would be some strategies we could use to make the table bigger, particularly for leadership? So that there's more seats at it for folks of all genders, particularly the underrepresented gender, the women and women associated.
Well, you know, the first thing that I just want to say really quickly about that is I think women, all of us, have to really, really take a moment at whatever point you are in your career and examine who is your authentic self and what do you really want? Because leadership involves sacrifice. And one of the things that I really think is important to recognize is that while people may tell you you can have it all, you can't have it all. And the piper gets paid at some point. So if you want to have 6 children and, you know, like be on the PTA, it's really difficult to be the chair of a department too. And if you know, want to be the dean of the medical school, it's just, you know, one has to find times in your life that you can fit all of it in. And while you may be able to have it all, you just can't have it all at the same time. So I think that the leadership question, you know, Kate, has to start with what do you really want and what are you willing to sacrifice to give that? And I think that women sometimes lose sight of the fact that these positions come with a lot of sacrifice, and one has to be willing to give up a lot of, you know, some personal comforts and time with family and other things to be in those places. And you know, look, there are things we can do to make it easier for each other, but at the end of the day, before the leadership question is asked, how can we make the table bigger, is do you authentically want to be there? And if you do, then it's like, come on, let's put in some table expanders and we'll make it happen.
Right. When you were talking, Catherine, my first reaction was you're absolutely right, because, there's not enough voices that are saying, you are allowed to make choices. You are allowed to prioritize what's important to you. You don't have to attempt to get it all, and we won't think less of you for not, making a run at that. Um, but then I said to myself, gosh, I wonder if anyone ever has these conversations with male identifying people, right? When they're like, I want to be in leadership, does anyone say, do you really want that? You know what you'll have to sacrifice for that? You'll get home later. I wonder if those same conversations happen. I'm not saying they don't. I would just be curious as to,
I think the unfortunate gender bias reality is that there are a higher, and this comes back to the data regarding burnout.
mm-hmm.
Men have fewer home responsibilities, right. And that has been shown in the literature, and it's a contributor to the burnout phase. And so I think that you're right. Maybe the same conversations are not had about, do you really want a position in leadership? But I think statistically, men have more support in the other elements of life that have to happen. And that's a generalization, but I think that it's true more commonly than not.
But some of those things that you alluded to, like, are equity issues that we need to figure out a way around. So we know that women, bear a larger portion of like their home responsibilities than, male physicians or male partners. And it shouldn't mean that women get left behind. So that's part of that equity piece that we have to figure out. And I certainly don't have the answers, but we have to figure out how, if our pay is based on getting from like an assistant professor to a professor, that if you're, like we have to figure out how we in the workplace can accommodate for like the additional needs that, young women have with respect to like, children and families. And so they don't get left behind in that regards, or else we'll never achieve that ultimate goal of equality. And I also think that there's things that, we've even been discussing at my own institution. One of the things that's really leveled that bar, COVID taught us a lot that, we used to have like grand rounds where, like 20 people were there. And now there's like 100 people because we do it remotely. And there's a big push to get everyone back into like on campus. And that disproportionately disadvantages my partners who it's much easier for them. They all are young with small children, and to not have to be out of the house by 6 o'clock to get there to be at a 7 o'clock grand round or M&M and then grand rounds. And so I think that those are simple things that we can do to close that equity gap, where we look for creative ways to allow women to tend to the diverse needs that they need to tend to, but still have equal opportunities at work. And I think we just need to get creative about it. And, when people want to, some of the progress that like learned some things during COVID and some of the studies that came out, and I think that some of those have helped women. And so not to, when the world starts pushing them back towards like the old way, to say, hey, like that's an equity issue, for probably a lot of people, but for sure for, the data shows it's definitely an equity issue for women, and being able to get there at 6 o'clock in the morning, that kind of thing.
Absolutely. And I think that, as trying as COVID was, it did really highlight some very relatively easy ways that we could make a presence in our professional lives more possible, whether that's through remote meetings or whatever.
Kate, we had this situation come up just last night. We have a 7 p.m. faculty meeting, and it's and I voiced that very request at the end of the faculty meeting. Would it be possible, at least quarterly, to hold meetings in person quarterly, so we could do a monthly meeting remotely. And there was a lot of resistance from the leadership to that request. I do find it very invasive in women's lives to have meetings at 6 a.m. and 7 p.m. And of course, they'll come back to you to say it's one time a month, why can't you make that sacrifice? But we all learn that these are cumulative, and it's not just one time a month. It ends up being multiple times in a month. And I just think that it's boundaries around work where meetings early morning and late night are considered normal. We do have to recognize that some reasonable expectations regarding boundaries for time outside of normal work hours that typically would end around 6 p.m. would be something that would be a reasonable thing to strive for.
Agree.
Yep. What other sort of actionable items have the two of you thought about or have seen come up in the literature that we can be aware of and sort of bring to our Urogyn spaces that would help make that gender equality a little bit more obtainable?
You know, it's interesting, a very practical, actionable item that I see is something that has not been done and I really need it to be done is flexibility of starting the OR day. You know, I find it fascinating that we have this massive bottleneck to get all cases started at 7, 7:15, 7:30, depends on, you know, whatever your institution starts. And, you know, you don't have enough anesthetists at starting all the cases. It's problematic to have everyone start at exactly the same time. And if they had some flexibility behind a rolling start, it really would allow a lot more women to accommodate the whole getting kids to school without losing the whole morning OR prime position. And honestly, I think if institutions would have rolling starts that started, you know, like from 6:45 until 8 as first starts, that would like revolutionize life for female surgeons.
Absolutely. And it doesn't even have to stop at the OR, right? Like, why are we not doing that with clinics or with other busy spaces where folks are jockeying for position, right?
Yeah, I mean, to the flip side of it, one of the things that we've done is we start clinic early to accommodate working women. So like, I don't have to get kids off to school. So it's easy for me to start my clinic at 7. So people that have to be at work at 8 can come in and get their in-person office visit before they go to work. You know, but I think that so much of it is, I just think that, you know, I think that one of the things I think is probably most important is, you know, Catherine alluded to it earlier. There's a ton of data about how we evaluate women, whether it's women evaluating women or men evaluating women. And I think that we really have to be so aware, so cognizant and thoughtful of how we evaluate women. And when you see these metrics where we know that women's, you know, female physicians have, or female urogynecologists have lower patient, less likely to get high top box likelihood to recommend, and they're more likely to get comments about like how much time they spent with me and about their personality and how they looked, that, and like all those type of metrics, you know, the patient reported outcomes, like those things hospitals end up linking to promotion, to success. And I think that we have to be so aware, even when they've shown that residents, female OBGYN residents get harsher evaluations from nurses than male OBGYN residents. So I think that like we have to figure out how we're going to evaluate people. And I also think that we're going to have to be really cognizant of, you know, many of us are sitting in leadership positions, that when you get these evaluations, what are you going to do with them and how are you going to interpret them? And I think that they have to be, you know, interpreted with the biases that the research has kind of shown that they have. We have to be intentional when we write letters of recommendations for people. I mean, that's where it starts. If we disadvantage medical students before they even get to residency because, you know, we're not describing women as superstar surgeons, leaders, then they're not even going to get to residency, let alone, you know, achieve higher level aspirations of leadership. So those are the two of the things that I often kind of think about.
And yeah, Kate, there's just one last thing to add that is such an actionable item that everybody has the power to do on a daily basis is the choice of sponsorship. And it doesn't matter if it's something small like an opportunity for a medical student that they wouldn't have had unless you actually created that opportunity for them. There's countless opportunities for residents, for fellows, and then junior faculty members. any opportunity that you have on an individual basis to just give a small opportunity to somebody who is underrepresented in that position is a step forward. And I think having awareness about that is supremely important. And if you can put not one name forward, but two female names forward, you're significantly increase the chance that one of the two of them will get it.
For sure.
Absolutely. And there's good evidence, if I'm not mistaken, that when there's concordance between sponsor and sponsee pairs in gender or other components of identity, that sometimes has advantages in the outcomes of that sponsorship, mentorship, relationship, whatever you want to label it as, because they feel that person understands their identity a little better.
Right. And I mean, to Catherine's point of sponsorship, we haven't talked about that a lot tonight, but you know, women are more likely to have mentors than they are sponsors. And, you know, that's probably the person that has to be your concordant pair, because they're the ones that are going to be like, oh, tell me about your life. Oh, yeah, you know, it's really hard for, I remember when my kids were young and that challenge of trying to get them off to school. Here are some strategies that worked for me while still being able to, you know, take on a leadership role at work, where I'm not sure a sponsor has to be concordant pair, because like all that person needs to do is put your name forward, you know, and then really, once your name's in, it's upon you to do the work to make them proud and want to sponsor you again, you know. And I think that I think about all the years I've been going to our big national meetings, and you know, I probably heard no less than like 700 talks about mentorship between SGS and OGS and APCO. And I have never heard a talk about sponsorship. And sponsorship is what's actually been shown to get people to the next level. Not just talking about how you're going to help someone, but putting them forward and creating opportunities.
Absolutely. And I think that's a wonderful point to wrap up our talk, because there's no one that is in this little live room, including all these wonderful folks watching, that doesn't have the opportunity to sponsor folks of all gender identities, and can't use that to leverage gender equality in our field and just make it a more pleasant place to be, not just for us, but for our patients too. I want to take the opportunity to thank the two of you doctors who are very busy female surgeons who I'm sure have a lot of obligations in all components of your life, for taking this time to not only poke around on the Instagram platform, which I know is something that is very foreign to some of us and very not foreign, and we're well versed in to others of us. And also to share your knowledge and your experience with the role of gender in our professional lives. So we really appreciate it at OGS and the journal too.
Thank you so much. And thank you, Kim, for teaching me so many things about this. And
thank you for
we really appreciate everyone's interest.
Yeah. Thank you for bringing this important topic forward, Kate, and, you know, giving Catherine the opportunity to work together, which we love to do, and talk about a topic that we think is so important and so near and dear to our own hearts.
Wonderful. All right, well, go out and sponsor some people.
Absolutely. Have a good one. Good night.
Have a great evening, Instagram audience.